Hello, everyone. My name is Warren Kinghorn. As co-director of the Theology, Medicine, and Culture Initiative at Duke Divinity School, it's my great pleasure to welcome all of you to this web conference on returning to church in pandemic. I'm particularly grateful to our Duke Surgery colleague, Tamara Fitzgerald, and to our panelists today. The ongoing COVID-19 pandemic has presented serious and, at least in our lifetimes, unprecedented challenges for the common life of Christian congregations and communities. Meeting and eating together for worship and fellowship and communion is a core part of being Christian. It is just something that Christians do. The writer to the Hebrews implores Christians not to neglect our meeting together, as is the habit of some. And contemporary research confirms that meeting together for worship and fellowship confers powerful benefits for social connection and for belonging, and can help to prevent and to counteract depression, anxiety, and loneliness. And yet, in a pandemic caused by a highly transmissible respiratory virus, that central Christian practice of meeting together can place others, especially those who are in high-risk categories, at greatly elevated risk of serious illness and death. And so for churches, COVID-19 poses some very important practical theological questions. First, if the church as the body of Christ is called to be with and for those who are vulnerable, then what does it mean for our practices of meeting together to place the lives of those who are most vulnerable to this pandemic, including older adults and those with chronic medical conditions, at the center of our concern? How might we center not only the lives of those who are at risk in our congregations, but also those who are at risk in our broader communities, since infection spread within a congregation will most likely to lead to further spread in a community, and since what congregants do at church will likely affect what we do and don't do outside of church. And of course, we're all to some extent at risk of death and illness from COVID-19. But second, this raises complex questions about access and who's left out when in-person meetings resume. It's easy to presume that those who are at higher risk from COVID could keep from getting sick simply by choosing not to come to worship. But this risks creating a two-tiered congregation composed of mostly younger and able-bodied people worshiping together on one hand, and others still excluded on the other. This may well increase the isolation and loneliness felt by those in higher risk categories, possibly even more than when everyone was having to find ways to connect without meeting in person. Congregations need to consider access for those at high risk for COVID in the same way that they often think about access for persons with disabilities. What does it mean for those who are at higher risk for COVID complications to fully participate in the life of the congregation as long as the pandemic remains with us? These are complex questions that many of you on this call have been considering at great length. Answering these questions wisely for your own community requires great theological and pastoral discernment, but it also requires accurate medical knowledge of how the novel coronavirus is transmitted and what might be done to decrease its rate of spread. That's our primary task today. And to introduce our panelists, I'd like to hand things over to my colleague, Catherine Smith, Associate Dean for Strategic Initiatives at Duke Divinity School.
Thank you, Dr. Kinghorn. And I'll add my thanks to you and to our distinguished panelists who are joining us today, and also all of you who are joining us from around the country for today's conversation. You are representing multiple states and even several countries, and we're grateful for you setting aside the time to be with us today. Before I introduce our panelists, let me say a brief word about the format for our brief time together. In a few moments, the panelists will offer some reflections on the present pandemic and some of the issues that you posed as questions in the registration process. After those reflections, I'll pose a series of questions to our panelists individually. But throughout the conversation, as several of you have already discovered, you're able to ask questions using the Q&A feature at the bottom of your Zoom window. If you see your question already listed by another participant, you can upvote that question by clicking the thumbs up sign, which will raise its profile in the thread. I also want to say, I know we're limited in time for today's conversation. We're not going to be able to address every question that's been raised. We do anticipate following up with participants to send some additional resources and to share a recording of the video once it becomes available. So thank you again for your patience as we try a new experiment, for taking the time out of your day to join us, and for the careful and faithful work you're doing in your congregations and in your communities. Now, to welcome today's panelists. Dr. Nathan Thielman is Professor of Medicine and Global Health in the Division of Infectious Diseases at Duke. His primary research focuses on critical issues that affect persons living with or at risk for HIV infection, especially in resource-poor settings. Dr. Thielman was also engaged in clinical research activities in West Africa during the 2014 to 2016 Ebola outbreak, and is helping to evaluate one of multiple COVID-19 therapeutic options here at Duke. Dr. Ibukun Akinboyo serves as the Medical Director of Pediatric Infection Prevention at Duke Hospital, where she's also an Assistant Professor in Pediatric Infectious Disease and is one of the hospital's epidemiologists. Along with the infection prevention team, she has led Duke-wide efforts to address, manage, and mitigate the COVID-19 pandemic. Dr. Andrew Alspaugh is a clinician scientist at Duke School of Medicine. He specializes in infectious diseases. He also takes care of patients with impaired immune function who are at higher risk for infections. His laboratory research focuses on defining the genes and cellular processes used by microorganisms to survive within the infected host. So thank you again to each of you for being here today. And with that, I will turn it over to you.
Thank you, Catherine, and thank you, Warren, for organizing this. Thank you, Tamara Fitzgerald, for bringing up this suggestion. Tamara is a pediatric surgeon and a global health colleague at Duke and a good friend, and we're humbled to be able to try to do this together. I want to thank Andy and Ibukun especially for lending their expertise and insights. Even this weekend, as we met together, we realized, man, there's a lot of ambiguity here. There are a lot of differing opinions, and we want to approach this with humility, recognizing that we're dealing with a lot of uncertainty together. So what we thought we'd do is just each of us would give a quick kind of opening statement. I want to focus a little bit on COVID transmission, and Ibukun's going to talk a little bit on some epidemiology issues, and then Andy is going to share with us some 5 guiding principles that I think are really solid. And before we go into just a little bit of the weeds here, I want you to know that each of us really cares deeply about the church. We approach these issues as people of faith who really care about the opportunities for us to get together again and to regather and to that sweet, wonderful fellowship that we experience in the church setting. At the same time, we recognize we're in this really difficult situation. In a lot of ways, it's so much easier to just kind of hammer everything down and say, hey, don't meet. And so now it's really tricky. How do we get back into this? And I think some guiding principles that I've thought about are we want to follow the science, right? We need to also recognize that our knowing and understanding is imperfect, and that science is I think it's getting better over time, but we've seen some issues even with the science as it comes out. But I do think we're getting to a better understanding, and our understanding will improve over time. With the whole goal, though, of mitigating risk as we regather out of love for our neighbors and out of love for our congregants. The final thing that I would just like to mention as we kind of start is that, and this is my opinion, is that in order to prevent transmission within churches, that we should surely do no less than what is recommended by local, state, and federal guidance. And I would argue that we actually, out of Christian love for our congregants and our community, that we should likely do more to prevent transmission. Could I actually see if we could get up a slide? We've only got a couple of graphics here. This is it, yeah. And I think this is actually what we all want to avoid. we do not want our church regathering to lead to fear within the community, because I think that would be essentially an anti-witness. You may remember what happened early on in South Korea with a religious gathering that wound up being a focal point for the epidemic early in that country. What's illustrated here in this graphic that came from the CDC is, and was published a little over 2 weeks ago, is how in Arkansas, a small church, there were 2 symptomatic persons who attended church events there in early March, and they later tested to be COVID positive. At least 35 of 92 who attended that church then acquired COVID-19, and there were 3 deaths within the church as a result of their gathering together. And then it spread from there within the community, and there were 26 additional cases and another death. That's what we don't want to happen. And so it's in that spirit that we want to really try to understand the science that's in front of us. Again, acknowledging that we don't have perfect understanding, but want to use that science to make what we think are really solid evidence-based recommendations, recognizing that there's not a one-size-fits-all here. May I have the next slide here? I just want to dive into really, I think this is the core issue. It's about how do we prevent transmission of this virus, now known as SARS-CoV-2, within the church setting. And here's what we understand about the transmission of this virus. We believe that it's primarily a person-to-person transmission that occurs. When we breathe, when we speak, when we cough or sneeze, air, of course, comes out, and within that air, there are respiratory droplets. And sometimes they're tiny. You understand it when someone sneezes on you, but you may not appreciate that even as we're breathing in and out, and especially as we're speaking to one another, we're actually exhaling these respiratory droplets. And sometimes there's actually aerosols, which is it's a kind of finer point in terms of transmission. But droplets tend to kind of come out and then they drop pretty quickly. And that's what's illustrated here in as number 2 there. Those are droplets, so they kind of fall to surfaces after traveling 3 or so feet. But aerosols actually can stay in the air for a longer period of time. There's actually one study that was in the New England Journal that showed this was a mechanically produced aerosol that demonstrated that actually culturable virus persisted in the air after 3 hours. So, that's a significant issue. So we need to think about that. So recognizing that droplets can do this, that aerosol transmission can occur. And then finally, we think there is some surface transmission as well. It's not as clear exactly how much of that is going on, but it is thought that another way that someone can catch the coronavirus is that potentially if you touch a surface that someone has coughed or sneezed on or has come in contact, their respiratory secretions have come in contact with it, then you touch your eyes, your nose, your mouth, then you may also transmit it that way. So I want you to keep those principles of SARS-CoV-2 transmission in mind as we kind of proceed through our discussion today. And Ibukun, let me turn it over to you to kind of tell us a little bit more about what the impact of this sort of transmission is.
Thank you, Nathan, and thank you to the group. I know sometimes the panelists are the ones that end up speaking for a good portion of this, but this only came together with a lot of people's efforts. I hesitate to say in the background because I think they should also be in the foreground. We have a very short amount of time here, and so to ensure that we are contextualizing all of the numbers that have been shared in the media, I just wanted to spend a few minutes talking through what the numbers may mean, particularly globally, nationally, and then what would make some sense for local numbers and what we should look at. So the slide that just got pulled up, thanks for doing that, is discussing numbers that I'm sure everyone is aware of. They change day to day. This was pulled yesterday. And across the world, we're nearing 7 million. We may have exceeded that as of this morning. And that's 7 million infected people. So these are people that we find the virus from somewhere. Most of them have been respiratory. So it was a swab of the nose. But some people may have had it within their stool, and some may have had it within their blood. The most likely source of transmission would be respiratory, and that's why we're tracking those the most. And just a point of reflection, there have been quite a few people that have recovered. That's where the 3 million comes from, and then over 400,000 deaths globally. I think in the United States, which is the map to my right, we're just under 2 million. I think I saw something this morning that we've exceeded that, and about 500,000 deaths and 110,000 deaths, sorry, and then 500,000 recovered. Large numbers are sometimes hard to grasp. So looking at the global numbers, I transitioned to Durham, where we are from North Carolina. If you want to put it from Maryland, and if you want to put that in some context, 6.9 million is just about the population of Maryland. And so that's the entire state of Maryland, everyone that lives in there today being infected. And then Durham, where we are, where we're based and where we're all having this conversation, is about 200,000. And so to put the global numbers in perspective, that's about the entire city of Durham, twice over, passing away within a 6-month period. And I think that is a huge point, and one that we can't miss. And so every decision we make, it's less so about how can we go ahead and practice something that is important to us, and how we have to consider how does this impact our local community, our global community, and how does it impact our witness. And I think the other point here is there are some arguments about when this was first discovered, but we learned about it December 31st, 2019. This was when the report was made from China, and the WHO quickly, they may have moved quicker, but soon afterwards shared that across the world. And looking at data over a 6-month period, we haven't really seen numbers like this associated with any infection. And there's been a lot of frustration about all the changes that have come out, all the lack of knowledge, all even the recommendations we make that change from one month to the other. And so I always encourage people when I'm discussing COVID-19 to just include some level of patience with this. We are all learning. If you asked us any questions about COVID-19 six months ago, most physicians would have had zero idea because it never really existed. And so we're all humans, we're all learning, and some of our conversation even today is reflecting guidance based on what's available today, but that may change as we go over the next few weeks into the summer as we learn more about this. So keeping that in mind, the categories of people that we know have done worse with COVID-19 tend to be people less than 65. I do think it may not just be related to some of the comorbidities, so having any underlying health condition. I think it's also related to the fact that our nursing homes in the United States tend to have people that are over the age of 65. And so we've had quite a few clusters of infections there, but then also just having any heart disease or lung disease seems to be associated with a worse outcome. And so having a congregation that's made up of people that are most likely to be infected or affected by this and have to go into the hospital or have severe outcomes, I think it does weigh into the decision, less about all the things you have to put in place when you actually open, but even about making that initial decision about when to bring people back together and in what format. And then the last point to make is that I am a pediatrician by training, and there have been numerous questions about what to do in congregations that have pregnant women and children. And I think the short answer is we don't know enough yet. We have not seen a lot of data suggesting that pregnant women are doing much worse. But as we know, we learn things about what happens during pregnancy typically long after the birth of that child. So we're learning a little bit more, but as far as we know, pregnant women and children by themselves in isolation are not necessarily at significant risk, but there are a lot more that we're going to learn about this, including the fact that some children that may have been infected before are now having a pretty significant inflammatory condition weeks afterwards. And that's a new syndrome that we're learning about. So I wouldn't go too much into the weeds about the epidemiology. I do think that when you are looking at data, it may be best to center on what's going on locally. And I did a quick review of just some states in the Northeast and the South and across the United States. Most states have a local public health department that reviews the number of people infected over time, the number of people that have recovered, and the number of people that have passed away from COVID-19. The numbers to pay attention to in a local environment should likely include the number of people infected as a moving average. So in the past week, in the past 2 weeks, are we seeing a trend upwards, or are we seeing a plateau or trend downwards? Note that as you continue to increase the number of people you test, you may find more people infected, but as you average that over time, it should stabilize if the rate of transmission has gone down. So if people are actually taking some precautions and not spreading this. So that would be what I would recommend, paying attention to your local numbers, either in your immediate city or in your state. And I'll take a break here and sort of hand over to I think Andy had a few slides to discuss the 5 principles, or one slide.
Thank you, Ibukun. It's a pleasure for me to be here as well. And what I'd like to do is just to discuss some principles that we know will help reduce transmission of this infection. We know that there are healthcare settings in which little transmission is occurring among the healthcare workers because they're following these general principles. We know that people are regathering in other places. And so if I can have the next slide, please. So these principles are probably nothing new to you, but I do want to review them. So it's important to screen ourselves and each other for symptoms. So when people are symptomatic with fevers, when they're having symptoms of a respiratory viral illness, they are likely infectious. Again, this is less important for many respiratory viruses, but for this one, there is a particular importance to make sure that we self-select, that people should not be coming together who have these symptoms either in small group settings or in larger congregations. Again, hand hygiene as we touch our respiratory secretions and have them on our hands, and then we touch each other. This is another significant mode of transmission, and hand hygiene will kill this virus using alcohol-based hand cleaners or washing hands. And then just simple environmental cleaning will usually prevent and reduce the virus transmission. As Nathan mentioned before, this is a respiratory virus that spread predominantly through an airborne route. And so things that will reduce our shedding and spreading of this virus include things like masks. So when I wear a mask, I'm not protecting myself, I'm protecting you from me. And I'm demonstrating my love for you by wearing a mask. And different barriers as well can also reduce it. So some kind of barrier that will prevent droplets from being spread from, I don't know, an enthusiastic singer or something like that, or a great preacher. But different barriers, be they a local mask or these are the ways that we can reduce those droplets, those aerosols that will infect each other. Social distancing, this is just very common sense, and it's a way to put in practice these other things. People who are a little bit distant aren't going to be necessarily physically touching, physically spreading the virus from direct touch. The transmissibility of this virus is all about duration and distance. The further we are away from each other, the less likely we are to transmit. The more time we spend together in close quarters, the more likely we are to transmit. And then just again, as has been mentioned before, when we think about these, special populations have to be taken into consideration. So I think that we are called to consider how to protect, how to minister to, how to love those people who will do less well with this infection. And does that mean excluding them? I don't think so. But again, now as we think about these principles, how do we apply, how can we begin to apply them? They'll have to be applied based on what Ibukun said is the local transmission rate. As the infection rate is increasing, that may be the wrong time for a congregation to get together. when we will see the epidemic go away. We will see it. And when we start to see reduced amount of transmission, these are factors that will help your local congregation to decide how to regather, not whether to regather.
Thank you so much to each of you for those good and instructive words to frame the rest of our conversation together. I want to start by turning to some questions that got a lot of traction in the registration process. And let me put this first one to you, Dr. Alspaugh. Can you discuss some church and liturgical practices? We had people who asked a lot about communion or Eucharistic practices, some who asked about baptism or other forms of gathering that might present special risk of infectious disease transmission, and what you might be seeing or what ideas there might be in addition to those you've named here to lessen those risks.
Yeah, what a wonderful question. And that's really sort of the meat of the day, isn't it? You know, we should be unapologetic in acknowledging that the physicality of our faith, that we do things, we touch, we lay hands on the sick, we administer communion and the Eucharist together, we sing, we embrace, and you know, these things are, you know, we baptize, we touch infants. And so anything that we talk about, we're not going to get rid of these practices, nor are we ever going to advocate them. But we need to think, well, at this point in time, how do we practice them safest for our congregation and for our communities, for a temporary situation? So, you know, for instance, you know, passing the peace. Let's take an easy one. Let's take some low-hanging fruit. Can we pass the peace among each other without embraces and handshakes? For a season, perhaps. I'm looking forward to passing the peace with physical touch soon, and I know that we will. But for a season of time, can we, as church leaders, demonstrate the leadership to say, just this simple act is a way to reduce and protect transmission and protect those around us. More difficult things, baptisms, you know, where there's much more physical touch going on. Maybe with children, maybe with, you know, and depending on your faith background, this takes on more or less eminent importance. But, you know, in any kind of delay in any kind of practice like this, but one could imagine that with well-washed hands and with masked faces, that things like this can be embraced sooner rather than later. I think the whole concept of the Eucharist is a much more difficult issue. I think, at least from, you know, and again, this is going to be very dependent on one's theological framework that you approach this and how one administers these sacraments. From my point of view, I think that sipping and dipping from a common cup with individual congregates, you know, actually, you know, participating in a real physical way, where that's a high risk for transmission. Now, are we saying that can never happen again? No. But I'm thinking that during this period of special increased risk of transmission, we need to rethink how communion may be offered. And you know, I think without the participants here, I have seen many different creative ways within your local congregation. It may be that the well-washed hands, the of a single priest who's giving out the host, you know, in a setting, to congregants who go back to their seats and take communion, that you know, that single element may be perfect for your congregation. That may not be adequate for other faith traditions. You know, individual cups somehow passed out by well-washed, well-hygiened hands may be the right answer. It may not be. You know, I know in our own congregation that, you know, that a priest participating in a Eucharistic activity and like taking these elements to the sick, you know, blessing them and then packaging them and distributing them to the congregation, so that at one point in common they can be taken together, but in individuals' homes or in an outdoor setting. These are examples, and again, just the way to creatively use infection practices and applying them to your congregation. I think one of the things that came up together among us as we talked this weekend is the something that you know better than I, but for such a time as this, you have been called to your congregation to leadership. And I'm so glad you have. I'm so glad that you are where you are, helping make these decisions and bringing the leaders together to speak as one voice, so that people can understand and agree to these practices.
Andy, can I jump in and certainly invite Ibukun as well, just to think about it together? I guess a couple of things come to mind as you say this, just reflecting. So I'm a preacher's kid. I'm a PK, that'll be familiar to a lot of folks here. And I remember Dad explaining communion to me and to our congregation as saying, just as really as you can taste and touch this bread, and just as really as you can drink from this cup, that really did Jesus die for your sins. And it's so the tangibility of our faith, the physicality, is so important in communion. And so I don't want to diminish that at all. At the same time, I look at the data from the CDC and I say, holy smoke, people have died because of these interactions in church. And so what can we do? And I totally agree with what you're saying. Use creativity, understand these concepts of transmission as best as we can understand them. And once you've got a grasp of that, then think creatively, how can I dispense communion in a way that I'm not going to infect someone? And also recognize there may be a time where you just, hey, we're going to have to kind of hold back and do it a little bit differently. I was reminded of John chapter 4, where Jesus is interacting with the Samaritan woman at the well, and the issue comes up of where do we worship? And is it here, is it there? And Jesus says, true worship is worship in spirit and in truth. As important as some of these practices are, I do think it's okay to reconfigure them as we move forward, and to have the freedom to do that is really important, and use the science that we have as we make rational decisions in how we dispense communion and engage in other liturgical practices.
Thank you to you both. And I deeply appreciate the invitation for congregations to think about their own particular theological tradition and how that informs the creativity that they'll bring to bear, what it means in different settings. That's a really important connection, I think, to make. Dr. Akinboyo, you talked a bit in the introduction about those who are particularly at risk, and we know that there are certain populations that are especially vulnerable. I think one of the things that each of us shares as Christian congregations is a call to put the most vulnerable among us first, and to build our community's actions and responses around those people. So can you say a bit about how we might help to prevent virus transmission specifically for the most vulnerable populations?
Yeah, I can talk a little bit more about that. I should also mention that one of my bias personally is the fact that we think of special populations sometimes from a medical point of view, but as some of you know and have seen just around what's going on, there are also certain groups that have been most affected by this, including people that have limited access to care, prisoners, certain racial groups, particularly for us here, African Americans and Latinos have been highly affected in Durham, and I'm sure in each community that may be slightly different, or people that are homeless and have not been able to seek some level of isolation in a place that's away from other people. So everything we say today may not address every single point or every single group that can be considered a special population. I think I would encourage all of us to take the church to the community, as I think we all try to do, such that there are advocacy groups, there are other people that have worked hard for the special the groups that I'm referring to as special population and see if we can support them in some way. Some of that can be just giving our time, some of that may be financially, and some of that could be prayers and support from afar. Coming back to when churches do choose to reopen, as I mentioned, some of the groups that are easily identified are those that fit some of the categories earlier. And I think what we've tried to do in other settings have been to suggest maybe staggered start times and separating some groups for virtual versus in person, and ensuring that the goal is not to meet the capacity of the building, but to encourage few people to start and see what happens in your community over time. There is no one size fits all guidance. The key groups that can be targeted would certainly be those that are older than 65 in your congregation, or those that self-identify as having any form of immunocompromising or altered immune system, and maybe preferentially offering them alternate options that do not require them to be physically in the church building for community with the church congregation or any other religious community. So that would be my initial advice. And then going back to what Nathan said, I think a lot of creativity is needed here to limit the feeling of isolation based on what has happened for 6 months. A lot of people have not physically interacted with others, but smaller group gatherings as we start to reopen in different communities, so less than 5, if that's what's legally mandated, can help with fostering that community as we go forward.
Thank you. A follow-up to that, which I think is partly related, we received lots and lots of questions about ways of sanitizing, how to clean surfaces, how to think about worship spaces and other spaces where people are gathered, everything from what kinds of products are most effective to how frequently, based on, should we clean based on frequency of use? Should we clean at certain intervals regardless of frequency of use? We also received questions about indoor versus outdoor worship. So could you comment just a bit on what are some of the best ways to think about sanitation of spaces and whether there are environments that might be higher risk to consider than others related to how we sanitize and clean?
Yes, we have one slide just addressing this. While I think we can argue back and forth about what we're called to do, about if this is persecution or not, I think cleaning is something that can be bread and butter. So this is a topic I can center on, and I think they're fairly straightforward answers that we can all come around. These are just suggestions, again, about resources that are out there. I'm basing my answer on the fact that my day-to-day role is in the hospital, which is a high-risk setting where we actually have people that are symptomatic and ill and are having procedures done that could worsen transmission. And we do not use UV light in our HVAC system. We do not use we don't have any type of fogging process. We don't really have any heavy duty cleaners outside of what we had previously designated as hospital grade cleaners. And the reason I'm sharing that is I think it may help with understanding what to do in a community setting where hopefully people that are coming into that setting are not actively coughing or sneezing or spewing out infection. So I would recommend that clean high touch surfaces, if there is a point of contact for everyone that has to come into that location, ensuring that there's an option to wash your hands before you touch the door would probably be ideal, or ensuring that there's a scheduled cleaning of high touch surfaces. And that could be hourly, it could be beginning and end, it may have to just depend on what works for your congregation. And then limiting shared equipment. So we know that despite our best efforts, we can contaminate our hands. And if I hand something to someone, in that brief second, if I've recently contaminated it, there's a risk for transmission. I think if something has been sitting out, similar to how people are receiving packages today, then we've not seen that as a form of transmission. It's not soft clothing, the pews that have cushions. If they've been out for a while, I don't think someone touching it would lead to transmission. So aggressive cleaning of all those surfaces may not be needed. And certainly you can't really clean paper. So it would be preferred if you can just limit the sharing of paper items as compared to trying to figure out a way to clean those things. And then the new part for congregation may be actually designating someone to clean an environment during service. I don't think that's necessarily always a part of most congregations, even though you have people that clean maybe afterwards. If a building has been shut down for months and weeks, just thinking through transmission, most things cannot really survive. And so there shouldn't be necessarily anything additional other than routine cleaning, and making sure people know where things are and they can reach out and clean themselves. We all have to take some ownership of cleaning things we touch, or cleaning areas that have been stained or soiled. And then one final quick point is that there are a lot of adverts out there about cleaning products. Coronavirus by itself is actually not a hardy bug or virus to kill off. And so things that have any type of cleaning agent, hydrogen peroxide, you can certainly use bleach if you want to, or really soap and water if you're washing your hands. I think all of those are sufficient. But if you would like a really thorough, exhaustive list, the EPA has it, and we will have the link in our resources. And it's also, if you have the slides, you can really just click on what I wrote in there, and those should be sufficient.
Thank you. That's terrific. And we will, just because a couple of reminders, we will follow up with a list of some resources and links to all the participants here today. And we'll also be including the full presentation, the full recording, once it's available. It'll be just a little bit of a delay so that we can close caption it to make sure it's accessible for any participant who wants to view it after the fact. But we'll make those available to you as well. One more quick reminder as we're moving forward, if you do have questions, please use the Q&A function, which is listed at the bottom of your Zoom window. And I can see that many of you have been posting them and using the thumbs up to upvote questions. We are turning to some of those questions next. So this is a question for Dr. Thielman. We had lots of people who asked about singing and preaching, and it has come up already through both droplets and aerosol, the ways that the virus can be transmitted. How do we think about singing and preaching and the ways that it contributes to the spread? And if normative worship practices could actually spread the viruses, what kinds of adjustments might be needed? Should we be wearing masks while we're singing and preaching? How do we safely sing, knowing that that is such an important part to many worshiping traditions?
So this is a really hard question, and I thank you for it. And I want to call on Andy and Ibukun to please, feel free to dialogue with me, push back on me. I think I want to be careful that there is not a one-size-fits-all answer here. I think it does depend on what's going on in your local environment. But I want to preface kind of any kind of specific issue recommendations with a story and a video. Okay, very quick, 41-second video. But first of all, I think it's a now infamous Skagit Valley choir practice that was in the news and has been written up in the MMWR, the kind of premier publication from the CDC, that occurred on March 10th in Washington State. And this was kind of pre-lockdown, but there had been enough coronavirus in the news to lead that group to actually suspend their usual hugs and handshakes, and they actually tried to sit a little bit further apart than usual. And according to the choir members who were present there, no one seemed ill. It seems like as they kind of went back, they did figure out that there was someone who was ill. They interviewed, no one seemed to cough. And the singing was as powerful as ever. And that was maybe the problem. The singing was really powerful. And what happens is when we sing, it's like a good vocalist is like a vocal athlete. They recruit, they get way down in their diaphragm, and they recruit these very small airways to belt out something. And when they do so, they actually aerosolize more smaller particles when that happens. And when you aerosolize smaller particles, then that means that you can spread more virus. So what happened with the Skagit Valley choir practice is, according to the investigation, 52 of the 61 or so choir members who were present actually fell ill. 32 of those tested positive for COVID-19 and 2 died. So this is pretty significant and it's concerning. And I think it does speak to the biology that I just tried to describe for you. If I could get you, Karen, to bring up the video, I think this will help to illustrate the issue with what a mask might do to help with that issue. So let's see. Yeah, hopefully you'll have some audio here in a second, but if not, I'm going to tell you that this actually came from the New England Journal of Medicine. I don't hear the audio, but I'll tell you that and if it comes up, that's great. If it doesn't, I'll just, okay. So this is without a mask. And what we're looking at are little fluorescent particles that are coming when, here we go.
Stay healthy.
Great.
Stay healthy.
Those are particles from the air droplets.
Stay healthy.
Good.
Are you recording?
Yeah.
Stay healthy.
Louder.
Stay healthy.
Louder.
Stay healthy.
Nothing.
Okay, I hope that made the point. But if you're able to track what was going on there, you saw these little fluorescent particles, droplets coming out when this fellow is saying stay healthy. And when a mask was put on, you don't see it. And that's kind of the function of the mask. It actually does, as Andy was saying, it does a whole lot more to protect your neighbor to wear the mask than it does for you to protect you when you wear a mask. Now, an N95 mask is a different story. That actually does offer a lot more protection for the wearer. But the reason to wear a mask is to love your neighbor. And so I would really argue that it's very important as we regather in the midst of an epidemic that we should be wearing masks out of love, especially for our vulnerable populations that are present. And especially because we don't know if we actually have it. So there's a lot of asymptomatic transmission that goes on with this virus. And that's the tricky thing in all of this. I mean, absolutely, we should be screening, and that's great. That's going to help eliminate transmission to some degree. But if we also wear a mask, because some of us are not going to have symptoms, that should help to prevent transmission quite a bit. The WHO just released a lengthy document on this on Friday, by the way, recommending that we wear masks. And I know that there's been a lot of back and forth on this issue, but if there's any doubt, I would really encourage us to say, look, out of love, I'm just going to wear a mask. So now to get to the harder stuff. Okay, so what about a choir? Should you have a choir? If you're going to ask me, and if you're going to say in my current local setting, where the risk of transmission seems to be pretty high still, I mean, if you look in Durham, North Carolina, the rates have really not abated. I would say no. I don't think it's worth the risk because we're going to be aerosolizing particles. What about a masked soloist? I think that's safer. What about an unmasked soloist? Well, I think that's a little less safe, but maybe some of these things could be mitigated with distance, with ventilation. If it's outside, that feels better. If there's symptom screening with that soloist, that would help. Like if you're a soloist in my church, I really hope you're not going to sing a solo if you have a sore throat, because I would just be really, we ought to be doing symptom screening for anybody that's up front that's not wearing a mask, mandatory. But I would actually also encourage you to think about actually wearing a mask. Another reason, okay, that's that. for maybe music, and there may be other questions. What about the preacher? That's tough, isn't it? Should the preacher up front be wearing a mask? And I think you could argue this back and forth. If they're many, many feet away, maybe, and they're not, hopefully they're not singing, but they may be projecting their voice very loudly. How far are those droplets going to go? How far might an aerosol go? I think I would feel better if they were way far away from the congregation. I'd feel even better, actually, if they wore a mask, but there's a trade-off there, because you lose this, like, what does that look like? And I lose something in my ability to communicate if I wear a mask. On the other hand, if I wear a mask, maybe I'm being an example to my congregation. Maybe I'm saying, hey, I care enough about you that I'm willing to kind of lose some of my communication ability right here, that I want to model this for you so that you'll model this for other people. I don't think there's a right and wrong here. I want to be clear, but I think it is important to really get into the details and think about what the trade-offs are. Might a preacher preach behind some plexiglass or get in one of those drum cages or something? Hey, maybe that would help. But if you understand the principles of transmission here, I think hopefully you can make a good decision. And Andy or Ibukun, rein me in here. Did I go too far?
I would add one quick comment.
Yeah.
I agree with what you said. I think so far, in an effort to ensure churches could continue services, there have been quite a few churches that have met in smaller groups, specifically groups that are singing or preaching occurring in settings where people have maybe 10 people within that church location and are spread apart in some way. And as far as I know, I don't think there's been a reported transmission from that occurring. That doesn't necessarily mean we need to advocate for it in every setting, but I think that having a phased approach where if you're going to have 50 people in a location and you have 20 people singing, that increases the risk a little too much at this point, versus if you're having 2 people singing in a large enough room that can accommodate 200 people and there are only 30 or 50 people, the risk adjusts. But instead of trying to figure out the physics of air movement and ventilation, I think I would just encourage people as much as possible, make sure everyone that is coming in is masked for the most part. If you cannot stay masked through the entire service, for whatever reason, singing, preaching, there's some distance between that person that's projecting and everybody else, and that all of the surfaces they come in contact with remain clean. And I think using those principles will be helpful. I don't know that every single congregation will be able to stay masked during all parts of the service. And so we just have to be careful about when we start, knowing that we may not be able to mask throughout the entire service.
I do hear some parallels here to higher education, where faculty members are imagining how to teach classes with masks on, and like preachers are concerned about being able to project and to be understood. I'm also mindful that as churches, we want to be sensitive to those with accessibility needs, and that masking protects and also sometimes makes it more difficult for those who might be lip reading or have difficulty hearing. So one thing that has come up in higher education are faculty thinking about pre-recording lectures, even if then the class meets in person in smaller sessions. Many churches that are outfitted with screens or projectors might still be able to pre-record or have a sermon done on video, even if in the moment of the service there is a community gathered. So it does sound like there are lots of ways to be creative. We're also now seeing more masks that have clear panels that can help for those that are trying to lip read. So just thinking about how to think about that for your own setting. In our few minutes, yeah.
One quick point before we end. I know there have been a few people asking about testing and screening. When we anecdotally refer to screening, I think what we're all talking about is just making sure you're asking questions about symptoms. I personally would not advocate for a church taking the onus of testing for COVID-19, antibody or the virus. And I'm hesitant right now to even say the church should be checking temperatures. I think there are many facilities that can and should do that. I don't know that the church is the best place to do that. But I think asking questions about symptoms, particularly for those that are going to preach or sing, may be important as part of screening. And that's all we were referring to.
Thank you. I do want to give just a moment here for any closing comments or thoughts from our panelists as we round out, and to be mindful that as we think about protecting those that are most vulnerable among us, one challenge that I know many of you on this call are facing is how to enforce and uphold the practices that you as a church leadership or as a congregation decide together. And we don't, I know that our panel necessarily doesn't want to give directions for enforcement policies for churches, but I do think that the language that you all have provided today helps to frame theologically why our adherence and support matters, and the ways that we amplify as a community are centering those who are most vulnerable and making decisions from there. So I'll turn to you for any last comments or thoughts. And also just an encouragement to those who are here that we know you have tough work ahead of you. We know that the decisions about implementing policies and practices and upholding them may strain relationships at times, and sometimes may even contravene practices of congregations in your community or of your ecclesial body. And so we are with you in that process and want to support you in that as well. Any final thoughts from our panelists today?
Just one brief thought. I think that the clarity of messaging and unity, as much as can be obtained within the leadership of your congregation, will be important to work on. And one thing that we discussed again as a panel, just one biblical image. When people were returning from, and Ezra, when they were returning from the exile, and were rebuilding the temple, there was great joy. But there was also grieving, because it didn't seem to be like the old temple. And I think in the same way that expect a lot of joy when we regather, but also be prepared for grieving and lament, and that will be a part of this process as well.
Yeah, I would second that. I think it's hard to not have clear answers, but we're comfortable with not having clear answers and looking for discernment. And I think that maybe now more than ever, there may be a lot of discernment that's needed in interpreting what's out there, and also interpreting it for the local congregation. And so I think just a summary statement would be, we hear you, maybe patiently reaching out to the leaders within your community from the public health point of view, and also just ensuring that the church has a united front as we're approaching this in terms of limiting transmission. But everyone is already, by being on this panel, you're already doing a lot. So thank you for listening.
I would echo those comments and just say too, recognize we're dealing with a lot of uncertainty. We're adapting. We have to be adapting to changing local epidemiology and even greater scientific understanding as things progress. And we need to be looking to local civic guidance. We need to be acting out of love. We need to be setting expectations, like Andy was saying, that it's going to be different when we go back, and there will be some lament. But the great thing is that we have the power of the Holy Spirit that will help us in tough times and will guide us. And we have the promise of wisdom when we ask God humbly for wisdom, that He'll give it to us.
Those are apt words to end by. Thank you again to our panelists. Thank you to all of you for joining us today. We'll follow up with you with some additional resources, and when the link to the recording becomes available, we'll send that to you as well. Go in peace and go in love. Thank you again.